Welcome, everyone. Today, we're going to take a really deep dive into one of the most intellectually demanding areas of our specialty, the anesthesia management of patients with significant valvular heart disease. Now, this isn't just going to be a simple review. We're going to build a comprehensive framework, starting from the underlying pathophysiology and seeing how that dictates every single decision we make in the operating room, whether it's for a routine non-cardiac surgery or for one of the cutting-edge percutaneous interventions that are completely redefining our role. So let's start with this question to frame our discussion. You've got a surgeon, and they're focused on the intricate mechanics of repairing or replacing a valve. It's a local, structural problem. But who is managing the entire system? Well, that's us, of course. While the surgeon is operating on the valve, we are, in a very real sense, operating on the patient's entire physiology. We're balancing on a hemodynamic tightrope where one misstep can lead to a complete collapse. You see, these hearts have fundamentally rewired their own rules just to survive, and our job is to master those new rules before we even start.
So let's begin by laying down those foundational rules. To safely manage any of these patients, we have to first understand the two fundamental ways a valve can fail, and, more importantly, how the heart's remarkable but ultimately maladaptive compensatory mechanisms create the very fragile physiology we are called upon to manage. Okay, let's dive in. All valvular disease boils down to two primary insults to the ventricle. First, you have stenosis, or a narrowed valve. This imposes a pressure overload. The ventricle has to generate enormous, supranormal pressures just to eject blood through a tiny opening. To cope, it compensates with concentric hypertrophy. The muscle wall gets incredibly thick, adding new sarcomeres in parallel. Think of it like a powerlifter building bulky muscle. In stark contrast, you have regurgitation, or a leaky valve. This imposes a volume overload. The ventricle is forced to pump the same blood over and over again. To handle this, it compensates with eccentric hypertrophy. It dilates and stretches, adding sarcomeres in series to accommodate the massive volume. This is more like a marathon runner's heart, large and compliant, but not necessarily stronger.
So let's apply this model to our first category, the high-pressure stenotic lesions. Honestly, these are probably the least forgiving of any anesthetic mismanagement. They demand our constant, unwavering vigilance from the moment the patient enters the room.
The absolute archetype of the pressure cooker problem is aortic stenosis, and there is one non-negotiable rule here. Hypotension is the enemy. It is the beginning of a death spiral. That thick, powerlifter heart has a huge oxygen demand, but its supply is incredibly precarious because the coronary arteries are perfused during diastole and high ventricular pressure compresses them. This leads us to our classic mantra: full, slow, sinus, and squeezed. We need the tank full to generate enough pressure to fill that stiff, non-compliant ventricle. We need the heart rate slow, this is critical, to maximize diastolic time for both ventricular filling and coronary perfusion. We absolutely must maintain sinus rhythm because that atrial kick can contribute up to 40% of the ventricular filling. Losing it is catastrophic. And finally, we keep the vasculature squeezed. We need to maintain a high SVR to ensure adequate diastolic pressure for coronary perfusion. For a non-cardiac surgery, this means any vasodilation from our anesthetics is a disaster. Regional techniques like a spinal are extremely risky. We have to prioritize stability above all else.
Mitral stenosis presents a different kind of pressure problem. Here, the obstruction is between the left atrium and the left ventricle. This essentially creates a dam for blood in the pulmonary circulation. The consequences are predictable. The left atrium dilates, leading to atrial fibrillation, and you get severe pulmonary hypertension that can lead to right heart failure. So, the primary anesthetic goal is deceptively simple: control the heart rate. A slow heart rate is absolutely non-negotiable. It's the only thing that allows enough time during diastole for passive filling of the left ventricle across that stenotic valve. Tachycardia is a complete disaster. It shortens diastole, which means the LV doesn't fill, cardiac output plummets, and blood backs up catastrophically into the lungs. We also have to be hypervigilant about atrial fibrillation. It's a double hit. You lose the atrial kick, and you get a rapid ventricular rate. Now, for preload, it's a very delicate balancing act. We need the tank full enough to support the struggling right side, but not so full that we cause overwhelming pulmonary edema. This is where a PA catheter can be your best friend.
Okay, now let's completely flip the script. We're moving to the volume-overloaded regurgitant lesions. And I want to be really clear here. The management goals we just established for stenosis are not just different, they're precisely the wrong thing to do. Applying a stenosis strategy here would be harmful.
For mitral regurgitation, our leaky chamber, the playbook is the complete opposite of stenosis. We summarize it as full, fast, and forward. We keep the tank full because these dilated ventricles are very preload dependent to maintain any forward stroke volume. We want the heart rate fast, up in the high normal range, say 80 to 100. Why? Because a faster rate reduces the time available for backward leakage with each beat, both in systole and diastole. And most critically, we promote forward flow. This means we actively reduce after load. We want to relax the blood vessels with vasodilators to make it much easier for blood to exit the aorta, which is the high-resistance front door, rather than taking the easy way out and leaking backward through the low-resistance mitral valve. So here, bradycardia and increased afterload are our enemies. They both increase the regurgitant fraction and can cause acute pulmonary edema.
And this brings us to a really fascinating and dangerous paradox in chronic mitral regurgitation. You can have a patient whose chart says they have a normal or even a supernormal ejection fraction, maybe 65 or 70%. But this reassuring number can be an incredibly dangerous red flag. So why is that? Well, think about it. The left ventricle is ejecting blood into two places, the high-pressure aorta and the very low-pressure left atrium. That low-resistance pop-off pathway makes it incredibly easy for the ventricle to empty itself. It's like judging a weightlifter who's only lifting half the weight because a friend is helping them with the other half. This artificially inflates the EF and can mask severe underlying myocardial dysfunction. The real test comes after the surgeon repairs the valve. Suddenly, that pop-off pathway is gone and the ventricle has to face the full aortic pressure all by itself. We call this afterload mismatch, and it can precipitate acute fulminant heart failure right there on the table.
Aortic regurgitation shares the exact same management goals as MR: full, fast, and forward. The basic problem is the same, a massive volume overload on the LV. The key difference is that the leak occurs during diastole, when blood flows backward from the aorta. Therefore, our primary tactical goal is to shorten diastolic time as much as possible. And how do we do that? With a fast, normal heart rate. Bradycardia in these patients is absolutely devastating. It gives a long diastolic period for blood to leak back, which simultaneously increases the LV and diastolic volume and drops the diastolic blood pressure, critically compromising coronary perfusion. It's a true double whammy. And just like an MR, we want to reduce afterload. This promotes forward flow and also reduces the diastolic pressure gradient between the aorta and the LV that's driving the regurgitation. Now, two other important conditions deserve a quick mention. First, tricuspid regurgitation. This is usually not a primary problem. It's a consequence of right ventricular failure from things like pulmonary hypertension. So our management is all about protecting that fragile RV. We maintain preload, we support its contractility, and we absolutely must avoid anything that increases pulmonary vascular resistance. That means no hypoxia, no hypercarbia, no acidosis. Then you have hypertrophic cardiomyopathy, or HCM. This is a unique beast. It's a genetic disease that can create a dynamic muscular obstruction right below the aortic valve. Now, paradoxically, the anesthetic goals here are exactly the same as for fixed aortic stenosis: full, slow, and squeezed. This seems counterintuitive for a hypercontractile heart, but it makes perfect sense. A full, stretched-out ventricle actually stents open the outflow tract. An empty, fast, or forcefully contracting heart will worsen the obstruction due to the Venturi effect. So we avoid dehydration, tachycardia, and vasodilators at all costs.
Okay, so given these incredibly complex and often competing physiological states, how in the world do we monitor them in real time? Well, our success hinges entirely on using advanced monitoring that gives us a direct beat-to-beat window into cardiac function. The single most important tool in modern cardiac anesthesia, without a doubt, is transesophageal echocardiology, or TEE. This technology has been a complete and total game changer. It's no longer just a diagnostic tool we use at the beginning and end of a case. It is now an active procedural guidance system. With TEE, we get these beautiful, real-time, high-resolution images of the heart. This allows us to confirm the diagnosis, precisely quantify the lesion, assess biventricular function, and, most importantly in the modern era, guide the surgeons or the interventionalists' catheters and devices with millimeter precision. It's our eyes inside the heart. And alongside TE, our traditional invasive monitoring with arterial lines and the pulmonary artery catheter, or PAC, remains absolutely essential. The PAC isn't just about the numbers, it's about what they tell us. It allows us to measure cardiac output, CVP, pulmonary artery pressures, and PAWP. From these, we can calculate systemic and pulmonary vascular resistance. This lets us translate those raw pressure and flow numbers into a comprehensive, real-time picture of the patient's hemodynamic state.
It tells us if our interventions are working, allowing us to titrate our vasoactive drugs and fluids with a much higher degree of precision.
So this brings us to the modern era, where our role has evolved dramatically with the rise of less invasive procedures. We are no longer just passively managing the physiology in the background. We are now actively and indispensably participating in the repair itself. In minimally invasive and robotic valve surgeries, while the surgical trauma might be less, the anesthetic challenges are often much greater. These procedures almost always require one-lung ventilation, which we have to manage expertly to prevent hypoxia and hypercarbia. TE becomes even more critical here. It's our GPS for guiding the placement of long venous and aortic cannulas that are inserted from the groin, and it's essential for ensuring a meticulous de-earing process before we come off bypass. Our job is to facilitate this complex technical approach while maintaining that unwavering hemodynamic stability.
Now, transcatheter aortic valve replacement, or TAVR, has completely revolutionized the treatment of aortic stenosis. Our role here can range from general anesthesia to, more commonly now, deep sedation. A key moment that we are central to is the valve deployment itself. This requires something called rapid ventricular pacing. For about 5 to 10 seconds, we pace the ventricle at around 180 beats per minute. This intentionally causes temporary, severe hypotension. It essentially stops cardiac motion and allows the interventionalist to deploy the valve with perfect precision. It is, in essence, a controlled hemodynamic collapse that requires precise coordination and our immediate readiness to resuscitate if anything goes wrong.
But perhaps the most perfect example of our evolving role is the percutaneous MitraClip procedure. Here, the anesthesiologist is truly a co-pilot for the entire case. In Step 1, it's our 3D TE imaging that guides the needle for the transeptal puncture, a critical, high-risk first step. In Step 2, we provide the imaging that allows them to steer the device across the atrium and position the clip precisely over the regurgitant jet. And then in Step 3, and this is crucial, before that clip is permanently released, we perform a comprehensive TE exam. We are the ones who provide the crucial, real-time data to decide if the repair is a success or if it needs to be adjusted.
And finally, in left atrial appendage occlusion procedures, our role is very similar. TEE is absolutely paramount. We guide that transeptal puncture, we help navigate the delivery sheath, and we provide the critical imaging to ensure the occlusion device is perfectly seated, that it's stable, and that it has successfully sealed the appendage without impinging on the mitral valve or the pulmonary veins. We perform the final comprehensive safety check before the patient can safely leave the room.
What all of this demonstrates is a truly fundamental shift in our specialty. In this new era of structural heart interventions, the cardiac anesthesiologist has evolved. We have moved far beyond simply being managers of physiology. We have become hands-on proceduralists, using our unique expertise in advanced imaging and complex hemodynamics to actively guide the most critical steps of these amazing repairs. We're not just at the head of the bed anymore. Our eyes and hands, through the TE probe, are right there in the heart with the interventionalist.
So let's conclude with this thought. Procedures like TAVR and MitraClip are constantly evolving. The devices will get smaller, the techniques will get slicker, the tools will continue to change. But the fundamental laws of physiology, the principles of preload, afterload, rate, and rhythm that we've discussed today, these are our timeless, unchanging guide. Mastering these principles is what allows us to adapt to any new technology and to ensure patient safety, not just by reacting to problems as they happen, but by proactively managing the unique, fragile equilibrium of each patient's heart.